Thank you. This is a recorded workshop because we do want this available on our YouTube and to be able to send to you all as well. So if there's anything that you missed or didn't catch, you'll have the recording to look at. But welcome. Thank you for coming tonight to this workshop about head and neck cancer presented by Dr. Veatch. I wanted to just start by, I guess I should introduce myself. My name's Abra Kelson. I'm a member of the cancer support community here at Northwest Medical Specialties. And I just wanted to introduce who we are and what we do here. So Cancer Support Community is the largest worldwide network of cancer support, and they provide free supportive programs to anyone affected by cancer. And so as an affiliate, we've been an affiliate of theirs since 2017. And as such, we've provided free programs to our community. So including workshops like tonight with education, but as well as social events, support groups, exercise. So we're really excited to be able to provide these to you all. So as we get started, I just wanted to go over some housekeeping. So you may have noticed upon entry that you're muted. We really just ask that you keep your mic muted throughout the presentation so we can really hear Dr. Veatch and get the most out of the presentation. We will have a time for Q&A at the end. And at that time, we'll have you unmute and ask your questions. And don't forget, there is a lovely feature. It's called chat. And, you know, as you have questions, as you're listening to the presentation, please write them down in the chat and we'll make sure to get to them at the end. The next tip, the last tip I want to give about housekeeping is in the right-hand corner, there is a view button. Now, if you click that and go down to the speaker view, that'll give you the best viewing option where you can see the full PowerPoint as well as Dr. Veatch as she's speaking. Okay, so just a few more things to go over. I want to let you know that these slides were reviewed by Dr. Michael Moore in April of 2021. Dr. Veatch has also had a chance to look over the slides as well. This is a program developed by the cancer support community. So they developed this content independently and had outside medical and psychosocial experts review it. The content and final control of this program is through CSE as well. Okay, so lastly is that Dr. Veatch has no financial relationships or affiliation, not being paid by Bristol Myers Squibb. They are a sponsor of this workshop for the cancer support community and the development. So just so full disclosure, everyone knows kind of where this is coming from and how it's been provided. All right, so I am going to hand it off to my wonderful colleague, Hannah, and she's going to introduce our speaker for this evening. Thank you.
Good evening, everybody. My name is Hannah, and I'm a patient access coordinator at Northwest Medical Specialties, also a member of the cancer support community. And I am here to introduce our presenter tonight, Dr. Andrea Veatch. Dr. Andrea Veatch is board certified in medical oncology, hematology, hospice, and palliative care with specialized interest in lung cancer, head and neck cancers, and other types of cancer. Dr. Veatch earned her medical degree from the University of Minnesota, Minneapolis in 1995. Following residency in internal medicine at Mount Sinai Hospital in New York, Dr. Veatch went on to complete her fellowship in medical oncology and hematology at the Fred Hutchinson Cancer Research Center, University of Washington in 2001. Dr. Veatch worked with independent grant support under Dr. David Maloney at Fred Hutchinson until 2004, when she joined Northwest Medical Specialties. Dr. Veatch is involved in numerous clinical research protocols as principal or co-investigator in lung cancer and multiple other cancer types. So without further ado, let's welcome Dr. Veatch.
Thank you. That was really nice. So it's nice to see you all. There's a lot of people that that I recognize. It's really nice of you guys to come and spend your time with us to talk about head and neck cancer and hopefully learn a little bit. And if there's any questions at any time, just jump in and ask if there's a way to do that with the with this format. And if not, then just we can answer all the questions at the end or in between. So, okay. This is what we're going to talk about. Just so you know, this talk was prepared by another person. And so it's not exactly how I would present things, but nonetheless, there's a lot of really helpful and applicable information. So hopefully you'll get something out of it for spending the time here. So I'm going to talk about, there's a lot of information on nutrition and the benefits of nutrition in patients with head and neck cancer. It's such a vital part of the care, especially or in particular with people who are getting radiation treatment to the head and neck area. So we're going to talk about nutrition and having a dietitian, the healthcare team, and then some nutrition related side effects, and then some treatment related side effects from treatment, and then also cancer related side effects and long-term side effects from the treatment and the cancer, and then some tips for maintaining nutrition after treatment. And there's a couple recipes that I'm not actually going to demonstrate, but there's recipes on here that are nice. And so I think there's a pamphlet or some information that's available. This booklet is available. If you guys would like to have a copy of it, we can make it available. So there's 16 recipes, and they're kind of kind for people who have head and neck cancer, difficulty swallowing or tasting, easy to prepare, and comfortable to eat. This is an interesting slide of the just the anatomy of head and neck cancer. So it's usually just defined as cancer that starts in the surface of the lining of the mouth, the tongue, the side of the mouth, and then down the top of the basically the aerodigestive system. So that's like the where it says uvula, that's the little thing that hangs down in the back of the throat. And then down the epiglottis is the cartilage that's behind the tongue that supports the tongue, and then the pharynx, and then down to the larynx, and then into the esophagus. And you can kind of see how the esophagus and the trachea are right next to each other. I've never seen this cartoon before, but it's really, actually, it's good. Okay, so head and neck cancer and nutrition, just because of the location of the cancer, nutrition is such a high stakes issue in head and neck cancer treatment. And so as far as symptoms of head and neck cancer, people who have cancer that starts in the mouth or the tongue tend to have their symptoms present their cancer at an earlier stage than if it's down lower, where they don't necessarily feel it or have it interfere with eating. And so that's one interesting thing about head and neck cancer is a lot of times it can be seen visually, not like with a CAT scan, but actually seen. And so one of the common symptoms is difficulty swallowing, difficulty tasting, or pain, or pain with chewing or altered taste. And so sometimes those can have, help people get to the doctor sooner than other cancers. Okay, so why is nutrition important? So the point is, I guess, before even starting treatment, some people have difficulty swallowing and weight loss and mouth pain. So it's important to pay attention to the nutrition aspect from the very beginning, from the diagnosis, and then all the way through the treatment then after. Thanks for changing the slides. So if someone presents initially with really poor nutrition and they've lost weight over the course of a year or two, or even 6 months, like 10% or more of the body weight is lost already, then they're really going into the treatment weak, like in a weakened state, and then it can compromise the outcome. And so it's helpful to focus on nutrition from the very beginning and try to improve the nutrition and keep the strength up, and definitely helps people tolerate treatment, definitely helps people stay out of the hospital. That can be a really tragic situation when someone's in the middle of treatment and they are not able to get enough nutrition, and then they're hospitalized, and then they miss part of the radiation treatment, which can compromise the outcome. And yeah, so I think that's all on that slide. So it's good to try to keep it's ideal to keep the weight, the same, or it's inevitable that people lose weight during treatment, but it's ideal to keep it steady. And so a lot of times we tell people to eat as much as they can before they start treatment to try to beef up a little bit. But it does matter what you eat, not just empty calories. And so definitely a healthy diet and lifestyle are really critical before, during, and after treatment to try to optimize your ability to tolerate treatment, and also the overall health, so that you can recover quickly and live well afterwards. Tooth decay is a problem with head and neck cancer because a lot of times, even if you go into it with perfect teeth, at the end of the treatment with radiation, a lot of times the salivary glands are affected by radiation, and then people have less saliva. And this saliva carries a lot of enzymes that breaks down bacteria and keeps the mouth and the teeth healthy. And with less saliva, the tooth decay really accelerates. And so I'm sorry if you guys can hear all these beeps. I'm not sure how to turn them off or whatever. But anyway, so after radiation with less saliva, the tooth decay can be quite quick. And so the dental follow-up needs to be more frequent than before, or really before any time in a person's life. And you can keep on top of it, but the saliva, there's really no good substitute for that. So that can be an issue. Okay, so head and neck cancer can be treated in a number of different ways, but usually it involves a combination of radiation, sometimes surgery, and often, not always, but often systemic treatment like chemotherapy. And so this slide just talks about some of the side effects of surgery, but these are actually side effects from all of the treatments. Basically loss of appetite, and so not wanting to eat food, but also altered taste and pain in the mouth, and pain with chewing, difficulty chewing, and difficulty with swallowing. And with surgery, you can have some numbness depending on the nerves that have been involved. If they've been severed on one side, then half of the mouth may be numb, or like hard to coordinate, and the taste can be off. And then the jaw muscles are really can really like atrophy and tighten up over time if it's not something that's consciously addressed during treatment and afterwards. So a feeding tube is a tube that goes either in the nose down to the stomach, like a tube that you slip into the nose and go down to the stomach, or a tube that goes straight into the stomach from the outside. It's put in through the mouth, down under sedation, down into the stomach, and then pops out the stomach. And then all the nutrition that's needed can be put through the tube. And so in general, people who are going through radiation and chemotherapy at the same time, a feeding tube is often recommended. Not everybody has a feeding tube, but it's very common and definitely can help maintain the nutrition during the treatment. Okay, so again, this is very similar to the last slide. There's some overlap on these slides, but basically, when people are going through radiation and chemotherapy, that loss of appetite is quite common. The taste can really be altered by chemotherapy, where the taste is metallic or just repulsive in some way, or just flat, like without taste. Not necessarily negative, but just not positive as far as flavor. And soreness on the side that's being treated is very common, as far as the lining of the mouth or the throat can become quite sore. Diarrhea and I'm sorry to jumping around here, but diarrhea and constipation can occur as a response to the tube feeding or to pain medication or dehydration. It kind of all of these symptoms can occur in all of the patients. So fatigue is very common. Definitely, I think everybody has fatigue.
Dr. Veatch,
Yeah.
we had a few questions that are coming in the chat. Did you want to take some of them now, or?
Oh, sure, yeah.
Okay, we had someone ask about the pain that you were talking about. Do you anticipate pain to last a lifetime, or?
I see. Yeah, I can see it now. Sorry, I didn't have the chat open. I see the questions now. So sorry about that. Yeah, so the pain, most of the time it's not for the rest of a person's life. But sometimes it is. If the nerves are damaged, then it can be permanent, but usually it's not permanent. So Sue, I don't know if that helped or not, but it's kind of a case-by-case situation. Most of the time it's not permanent. Oh, Sue, you have all of the side effects. I'm sorry. Maybe we can help though. I mean, maybe this can be helpful. I hope we can help in some way. Was there any other side effect? I mean, any other questions? I didn't see any that were.
So there was one more. So the person said that I'm interested in common protocols for surveillance scans follow-up. What is the usual frequency for post-treatment scans? When are CTs done and when are PET scans done? Yeah. I'm not sure if you want to talk about that now or if there's a place later on.
I think it'd be better to talk about that later.
Okay. Yeah. Okay, thank you.
Yeah, thanks. Okay, so feeding tube is, okay, so in the setting of radiation and chemotherapy, sometimes surgery followed by chemotherapy and radiation, a feeding tube is recommended. And the benefit of the feeding tube is that then a person can maintain their nutrition the entire time that they're getting treatment, even if they physically cannot swallow. And that can be problematic during radiation primarily, or sometimes after surgery, that it's just technically very, very painful or difficult to swallow. And so the feeding tube is like an insurance policy that you're going to get your nutrition, even though it's still very important to continue to try to eat every day and swallow every day, so that your muscles of the neck and the throat continue to fire and work so that they don't atrophy. There are some times when the muscles of the neck and the swallow apparatus just freeze up and they stop working, and then a person's not really able to protect their airway when they're swallowing, and they become dependent on the feeding tube indefinitely or lifelong. But that's rare. It's like maybe 5% of people that go through treatment end up having a permanent feeding tube. That's an exception, not the rule. And so usually what happens with the feeding tube is people get it in if you're getting radiation and chemo, which is the most common scenario for people with this, but obviously not all the stages are treated in this way. But if a person's getting radiation and chemotherapy and they get a feeding tube at the beginning, it's more just kind of like a nuisance because they're not using it. And then they start to use it and depend more on it during the treatment. And usually the last 3 weeks or so of the treatment out of the 6 or 7 week course of radiation, the feeding tube becomes more and more important and able to really to provide all the nutrition, even if you're not hungry or can't swallow. And then, but you continue to try to eat all the way through. And then as soon as after you're finished, your tissue starts to heal, you're able to swallow. Then we just take the feeding tube out. As soon as a person's able to maintain their nutrition, they don't need the tube anymore. So it's a temporary bridge to get through the difficult part. Okay, so this is a patient just basically saying that the radiation and chemotherapy, so radiation doesn't always have chemotherapy attached to it. Sometimes it's just radiation by itself. But in either case, it does cause inflammation, irritation, and pain in the mouth and the throat. And really, what she's saying is it's just going to be hard to swallow. And if it does become hard to swallow, then to not be shy about getting the feeding tube, because that it just takes all the mental pressure off of like your survival depends on swallowing, and you have to get those calories in, and it can become extremely stressful when you're already in pain and going through the treatment. And so she's just encouraging people to consider the feeding tube if there's a point that they need it. A lot of times we discuss this at the beginning and get it put in at the beginning. So it's not something you have to decide in the middle. Okay, so dietitians are really helpful for people that are going through treatment with head and neck cancer. They can help with the feeding tube. They can help with the different formulas of the feeding tube, and they can sometimes people don't do well with a certain formula, and they need to have the formula changed. But also they're just really helpful with regular food. What's a good diet? What's good nutrition? What's easy to swallow? And what's generally pleasing to the taste buds and that kind of thing. And so we like to have a nutritionist involved when people are going through head and neck radiation surgery treatment. Okay, so the weekly follow-ups during treatment in the first 3 months, the appointments that they're referring to is when a person's going through radiation and chemotherapy. We like to see them every week. And the reason why is because things can be going well and then all of a sudden they're not. And this was one of the first things that I learned when I started practicing, is that if you wait 3 weeks in between seeing people, there can be a marked difference. And we can catch things earlier and help people earlier if we see them once a week during the radiation. So it's really, really important. These are some of the things to basically tell your providers about weight loss. I mean, we check everybody's weight every week and look in their mouth and try to get a sense of how they're doing overall. So yeah, it's really important though to complain a lot when you come to the doctor and the providers. It actually doesn't, even though I have a lot of admiration for stoic people, a lot of admiration, it really doesn't help me to help them. So it's okay to just like, you have full permission to complain or express any concerns at any time. So yeah, so this has to do with there's a lot of feeding tube and nutrition on this talk. So this has to do with basically if the feeding tube is causing symptoms like nausea, vomiting, there's different rates that that you can put the food in. Like, for example, there's bolus feeding, or there's a gravity bag, or there's a pump. A pump goes like a teaspoon an hour, very slow for people that really can't tolerate it much faster. And then there's a syringe where you basically just shove like 2 cans of food in 5 minutes. Some people just do it that way, and they're not bothered by it. So everybody's really different. It requires a kind of case-by-case management of how a person actually puts the food into the tube. And the tube itself can cause problems. Sometimes people call at night and their tube is clogged. And so there's little tricks that we try to recommend. There's different formulas that you recommend to unclog the tube. And then sometimes the tube just needs to be exchanged over like a wire and put a new tube in. And so that's also an option. And then there's also financial stress to the feeding tube. Some insurances don't cover the tube feeds. And so there is I mean, it's like they consider it like, well, you have to buy your food. And so you should just buy this type of medical food. And so sometimes the food can be expensive for some people if it's not covered. So these are the same things that we've already talked about. Mouth pain, difficulty swallowing, dry mouth from basically loss of saliva. The changes in taste and smell can be permanent, but not always. Sometimes it'll take up to 2 years after the treatment for the taste or smell to recover to the state where it is going to be. From there, it may not be what it was before, but sometimes it is what it was before. But it can be take a long time for that to recover. Nausea and vomiting can be from the tube feeds, but also it can be from the chemotherapy. So those can be addressed in different ways. And then weight loss is very common during treatment. And then diarrhea and constipation, usually one or the other, but sometimes people go back and forth, is common too. So the idea of this is, I'm so sorry, is to try to find foods that you can eat and try to continue to eat the whole time that you're having treatment. And so these are just some examples of foods that are easy to eat, cold, soothing foods, like wet foods, slippery, like the easiest thing is slippery foods. And then everything that's warm, it needs to really be often like not greasy, but like watery, like gravy, kind of heavy on the gravy kind of thing. Whereas acidic and spicy foods and crunchy hard foods, well, I mean, this is like really intuitive. People would know what to not eat, but these are very obvious things to avoid when your mouth is painful. Okay, so this is great. This mouthwash, I mean, I tell people maybe 5 or 6 times a day to rinse their mouth out with salt water or baking soda and water. This is actually the one way of preparing it: a quart of water with a teaspoon of baking soda and half a teaspoon of salt, and then just mix it up, and then just take that quart with you all the time and gargle it and spit it out every hour, even like just all day long. It really helps a lot with any kind of mouth sores from any kind of chemotherapy and radiation, basically not just head and neck cancer patients, but basically all cancer patients can benefit from this. And then ice chips, just like any other injury, ice helps reduce the pain. And so ice chips can be helpful. And then drinking on a straw, the idea of that is putting the straw behind the tender area in the mouth and just kind of like putting it past the bad taste in the tongue or the soreness, and just drink over it. Okay, so oral care is having to do with keeping your mouth clean. Brushing the teeth can be difficult, but there are some special mouthwashes, or not mouthwashes, but toothpaste that doesn't have, that's not painful. And so that's it, like alcohol-free mouthwash. There's also toothpaste that's less painful. And so that's really helpful. It's so important to have a good dentist. At the beginning, usually the dentist looks at your mouth, and people have extractions of teeth that are look like they might need to be pulled within a time frame of maybe a year or two. If there's wiggly teeth or teeth that just don't look right, they usually extract the teeth before radiation starts, and then they give you these fluoride trays and fluoride toothpaste and stuff to use during the treatment. And then the dentist follow-up after treatment is about twice as frequent as normal dental visits. And so there are a couple dentists that are more savvy about radiation and more informative, but the dental care is really, really helpful. It's not uncommon for people to have no teeth though when they start treatment, or have all their teeth extracted before the treatment, and that then they get the dentures down the line. Okay, so the difficulty swallowing, and as a consequence of the inflammation of the throat, basically, the idea of this is to try to get as many good calories as possible in soft, easy to swallow food. And so blending food is really nice because you put a lot of protein and not a lot of sugar and kind of wasteful calories, just to try to eat as healthy as possible. And blended form is good. I have some patients that have not purchased food. They blended it and put it through their feeding tube the entire time, and that's a lot of work. But it's great when people do that. And then avoiding hard foods, tough foods, scratchy. It's basically common sense. Yeah. So yeah, this is the same idea. Just making foods runny, soft, taste good. This swallowing a spoonful of honey before radiation is an interesting tip. I have not heard that before, but that sounds great if it's helpful. And this coughing business, when a person swallows and they cough right after that, that's a really concerning sign of aspiration. And aspiration means that the airway is not protected, that the food is even phlegm is going into the lungs instead of into the esophagus, and that can cause choking, and it can cause pneumonia, and it actually is what my father passed away from. So it's really important to keep the airway protected. And so when a person coughs after eating, it's something to definitely pay attention to. Okay, so the saliva with radiation, the saliva factories are damaged, and so you can't actually control that. But these are little tricks that help make the saliva a little bit more more active. But there really is, it's an irreversible damage that's done often, and there's a million products on the market, and they all don't really work that well. And so these are nice ideas, and they're worth trying for sure, but they may or may not be helpful. The main thing is like they're saying, to moisten foods with sauce and gravies, and chewing gum. Lime and lemon cause a contraction of the salivary glands, but it may not be tolerable if the mouth is, if that's painful. Yeah, avoid doughy breads. People tend to struggle with bread and chicken and meat, dryish meat after treatment. Bread, sometimes people just can't get it down, just balls up and can't swallow it. You can go to the next slide. So dry mouth can be made worse by anything that dehydrates a person, like alcohol and caffeine are actually diuretics. And so in other words, like if you drink 8 ounces of alcohol, you urinate out more than 8 ounces. So you might urinate out 12 ounces or 10 ounces. After drinking alcohol or caffeine, you're at a net loss as far as your hydration. And so so that's what they're getting at. If you're getting dehydrated, then your mouth is going to be more dry. And so it's just generally helpful to know that if you drink 1 caffeinated beverage, you should also drink the same amount in water, just to stay a little bit ahead of your hydration. Otherwise, you definitely, if you only drink caffeine, three coffees by 10 a.m., you're getting very dehydrated. That's kind of just a side note. So there's a lot of saliva substitutes at the store that some people have benefit from these, but generally I would say there's not one in particular that I would recommend strongly over the others. And lip balm and petroleum jelly are great. Actually, Aquaphor is the best. I think Aquaphor is kind of like flour for a baker in this field. Aquaphor is just good for everything on the outside. It helps it heal, and it's soothing and comforting. I don't know if everybody's heard of that, but it's like over the counter emollient called Aquaphor. So, and the humidifier sometimes helps also with the oral, like the mouth and the throat dryness, to reduce that. Okay, so if everything tastes bland or has no taste, then clean your mouth with baking soda rinse. If your mouth isn't irritated by acidic foods, you can try stronger flavors, such as pickles, condiments, and sauces. Add spices and seasonings, marinate meats for a stronger flavor, or suck on tart candies before or after a meal. If everything tastes metallic, try using a plastic spoon, not cooking with iron skillets, and to avoid red meat. Tends to taste more metallic than the other sources of protein. And then maple syrup can offset the bitter taste sometimes. So smell aversion is an interesting symptom, like being pregnant, I think. So this is advice to the person who has an aversion to the smell. Basically, avoid the area where food is being prepared, and go outside or sit by a window, and or just eat cold foods that aren't being cooked, or try a candle or oil diffuser. Okay, so nausea and vomiting can be caused by the chemotherapy that's used for head and neck cancer. These are kind of remedies for that don't include taking nausea medicines. So small, more frequent meals, room temperature foods, ginger ale, ginger candy, ginger tea, dry, bland foods, and to avoid heavy and greasy foods, because those definitely make nausea worse. Meditation, guided imagery. Yeah, and then nausea medicines are normally prescribed prior to this treatment. And try to keep a little bit of food in your stomach all the time. That's a very good tip. Okay, yeah. So, and the other thing is, yeah, if you can try to eat like high calorie foods, so it's more concentrated, less volume, then you're not having to force a lot of volume of eating. These are just high protein sources, nuts and nut butter, which can be blended nicely, beans and seeds, meat, fish, poultry, eggs. Dairy products are kind of, I would say, case by case. Some people get a lot more phlegm when they eat a lot of dairy products going through treatment. Okay, yeah, so these are like basically high calorie foods that are easy to swallow and are very nutritious for the most part. Avocados, one of the best things if a person can swallow avocados, and then olive oil, of course, is very, very healthy. Nuts and seeds can be difficult for some people. And then you can see the rest: cheese, gravy, peanut butter, dried fruit. You can turn this slide. Okay. Sorry, I'm sorry, I missed that one. Okay, so yeah, just adding additional calories to oatmeal, adding additional calories to, like, this is a great idea, adding olive oil to soup or cheese or sour cream. Avocados are really good. I think nuts might be problematic, but just increasing the calories. So for constipation, high fiber foods. Yeah, okay. So high fiber foods help promote the absorption of water into the bowels, and then that helps kind of keep the bowels moving forward. And prunes and prune juice, that's actually a laxative. So prune juice is quote natural, but it does irritate the lining of the bowel, and your bowels can become addicted to prune juice, just like X-Lax or any actual laxative. So that's just something to be aware of. And then hot beverages can help move the bowels as well. Being dehydrated definitely causes constipation. So the more a person can drink, the better. And yes, these gassy cabbage, broccoli, cauliflower, those can cause gas and bloating. Yoga is great. So the main thing I think with this is just that there's kind of two, like as far as medications and over-the-counter treatments for constipation, there's basically two ways that they work. One is that the fiber type things, like actual fiber in the food, or Metamucil and Citracel and Miralax, those type of things bring water into the bowels, and then it makes it easier to push it out. The bowels are softer. They don't cause any irritation or damage to the lining of the wall of the bowel, whereas even senna and prune juice and any kind of laxative, it actually irritates the lining of the bowels, and your body gets really addicted to that very quickly, and then you can't have a bowel movement without it. And so it's better to avoid laxatives and use the powders or high fiber to bring the water in. And then if you're still backed up, then add a laxative temporarily. So like, for example, a common thing we tell people is to take Miralax every day with a glass of water every day, even if you're not constipated. And then if you're constipated, despite that, add a laxative, but just until the bowels move, and then stop it, but continue the Miralax or the fiber. So yeah, that's it with that one. Okay, so these are foods that can make diarrhea worse. Raw vegetables can and nuts and whole grains can make diarrhea worse. Dairy definitely irritates the lining of the bowels. I mean, dairy is actually really irritating to the lining of the bowels from all the way down. Not for everybody, but it can definitely be implicated in diarrhea frequently. And then high sugar foods basically can cause overgrowth of bacteria that are not healthy. And so that's the idea of like not eating a lot of concentrated sweets. And greasy and fried foods can cause constipation as well as alcohol. That just has to do with dehydration with the alcohol. Okay, so these are, I guess, foods to eat when you're having diarrhea. These are basically the brat diet, or rice, plain potatoes, oatmeal, baked chicken, applesauce, bananas, canned pears. These are like very gentle, very easy to digest foods, just so you get some nutrition when someone is having diarrhea. And then to drink fluids with electrolytes, it's very helpful. Coconut water, broth, electrolyte drinks, and diluted fruit juices. Like regular fruit juices are just full of sugar, and so those can sometimes aggravate diarrhea. Probiotics are great. So yogurt, one thing that helps a lot of people is kefir. It's basically like yogurt with a lot of healthy bacteria. Probiotics and are a little bit controversial amongst oncologists, but I think that they're very helpful for general health. And yeah, if you have more than 3 runny bowel movements, it's good to call us per day. So yeah, I love this. People that take a journal, some of you, in fact, in the audience are like accountants with your symptoms. I love that, with all the details and everything. It's so helpful for the caregivers, but it's much more helpful, I think, for you to see the patterns and what irritates or what's helping you. So I think a symptom journal is a really good idea. And the dietitians also like those a lot. I love it. I love it when people keep a symptom journal. Okay, yeah, that's all on that. Okay, yeah, so having definitely helps to have people around, like that, family and friends that help. There's no doubt about it that people do better when they have someone that's kind of a caregiver role looking after them as far as symptoms. And cooking in bulk is a great idea to do that when you have more energy. And then set a menu, an eating schedule. The eating schedule's kind of easy with the feeding tube. You just like, I'm going to feed at 8, 12, 4, 8. It's like having a schedule with it. Just very regimented schedule is very helpful. Okay, so let's just say someone's finished radiation and chemotherapy. It does take some time to recover. It can be a couple of weeks before people start to improve, and hopefully they've been eating the whole time, and then just eating more and more. And the feeding tube can be removed once a person's hasn't used it for 2 weeks and they haven't lost weight during that period of time. Food and food, the role of food after treatment is difficult. Some people, food is more important than others, and there's definitely new flavors. Things don't taste the way that a person remembers, but people do adjust over time and may not taste the same, but they get a new normal. And the main thing is to get enough nutrition and just try to not lose, continue to lose weight. So, but anyway, we're always here to try to help with these things. The nutritionists are just fantastic as well.
Dr. Veatch, we had an incoming question. Would it be okay to ask right now?
Yes, of course.
Are there any new innovative treatments for head and neck cancer that you've been seeing out there recently?
Yes. So, the thing is, it depends on the stage of head and neck cancer. So there's 4 stages, And just to kind of go through it real brief, the stage 1 and stage 2 are treated with radiation and surgery, and those have had some technological advances, recently. Like the radiation now that's given now is significantly better than the radiation that was given 10 years ago, and markedly better than what was given 20 years ago or 30 years ago. And so there's been a lot of advance in radiation. As far as surgery, a lot of advance in that as well, as far as just like trying to preserve the normal tissue. And they robotics are very precise. They use a microscope. It's really high tech. As far as systemic treatment like chemotherapy, we don't give it any chemotherapy or systemic treatment for stage 1 and stage 2. Stage 3 and 4, we add chemotherapy to radiation or to after surgery. And then stage 4, there's several levels of stage 4. And so if the cancer has spread outside of the head and neck area, then we don't usually use surgery or radiation, at least not upfront. We just do chemotherapy or systemic therapy. And so in that arena, there's been advances in terms of molecular testing and testing mutations and targeting treatment, and then also in immune therapy. So like Keytruda and Opdivo are given in head and neck cancer. Those are fairly new, I'd say like maybe four years or so. But the chemotherapy that's given with radiation, cisplatin, that's the same chemotherapy that's been given for a long, long time. There hasn't been a clinical trial that showed anything else superior to that so far. So in that stage, cisplatin, radiation, there's been no change. Hopefully that was helpful.
Thank you so much, Dr. Veatch.
Mhm. So so this is basically a summary, I guess. Check with your healthcare team regularly and write down questions and complain a lot. Keep a food diary, keep a just general diary, medication diary, and then call with any kind of symptoms of concern, pain, redness, swelling, skin changes, skin burning, difficulty swallowing, difficulty opening the mouth or closing the mouth, choking, any kind of tube feed issues, pain, new pain, change in pain, weight loss, tooth pain. I mean, we meet with people usually pretty frequently when they're going through this. And so it's not hard to have time to discuss these things each time. I think we might have already talked about this, but basically you try to just keep trying to eat, and as soon as you're successful enough to keep all the nutrition that you need without the tube, then we take the tube out. But it can be a long process. Sometimes the tubes, people keep a tube in for a month. Afterwards would be probably the minimum, and some people still have a tube 6 months after radiation, but I'd say the average is two or 3 months after. Then people mostly get the tube removed. Main thing is swallowing. Like some people actually just drink the tube feeds instead of using the tube. I think we've already covered that. Yeah, it can be a little tricky when things don't taste like how they're supposed to taste, but definitely avoiding irritating foods is a good thing. Citrus and tomato and spicy foods are irritating. And be patient, yes. Sometimes the feeding tube will fall out and or get pulled out by accident. Sometimes someone will twist in bed and the tube will be pulled out by accident, and then it can be put back in fairly quickly. If a person goes to the emergency room, it'll close, that hole will seal off within maybe 8 hours. And so when a person's done with the feeding tube, it's just literally pulled out, like just yanked out. And so that hole just closes up pretty quickly. So it doesn't need stitches or anything like that usually. But if it gets pulled out by accident, then it does need to be put back in quickly before the tube seals off, before the tunnel seals off. So yeah, take good care of your mouth. Okay, so these are long-term side effects from people who have had surgery and radiation for head and neck cancer and chemo, but usually not with just chemo. So the dental issues, like I mentioned before, can be problematic. You can get more rapid cavities. And so the problem is after radiation, if you have a tooth that needs to be pulled and it gets pulled, that area of the jawbone may not heal. And so there's a condition called osteoradionecrosis where the bone didn't heal, the tooth is out, the bone is exposed, the gum is not covering it. Can be very difficult. And so people have to have surgery where they scrape off the dead bone, and then they have to have like hyperbaric oxygen and sometimes surgery to cover it. It can be quite problematic. And that's the reason why it's best to have any marginal teeth removed before radiation rather than after. And then muscle and jaw problems are helped with I'm sorry, I said nothing about speech pathology during this whole thing. These people are very important for swallowing, the muscle coordination, the swallow coordination, keeping the jaw flexible and so that you can open it. Speech pathologists, this is what they do all day. And they're just really helpful with this. And then swallowing can be a long-term problem. There are some times when a person really isn't able to protect their airway, and even sometimes years after treatment need a feeding tube, even though their cancer's gone and everything's fine, it's just scarred and they can't protect the airway from swallowing. So a feeding tube can be used in that situation. And the taste changes can be permanent. Weight loss usually wouldn't be permanent, but sometimes it can be. This is a total side note, but I just want to mention to all of you that there is a website called Support for People with Head and Neck Cancer. It's a wonderful website. And I'm thinking now that a lot of this came from that website. It's basically very helpful, practical information, but we can share that website with you at the end. So these are just tips for long-term survivors. Chew your food well. So I know a person who was at a very fancy gala and choked, and his wife had to do dig in, it was bad. It's really hard when you're in a social situation and you're trying to be social and talk and eat at the same time. And so I guess I just want to point out, just try to always stop and talk and then eat small portions, focus on getting that food down when you're in a social gathering. And then feeding tubes that are permanent do need to be changed out every 3 months or so. I think that's mostly on that. Yes, this is good. Most definitely not a life-ending deal, but a life-changing deal. It's tough treatment for sure. So yeah, we're done. So this is a banana melon smoothie. I didn't come up with this myself, but very easy. It's frozen fruits, chia seeds, whole milk, and yogurt blended up. Drink it. We have these. If anybody wants these recipes, you can have them.
Dr. Veatch, do you want me to just these will be available to everybody after their presentation. So I mean, we can just kind of breeze through these and it will be available to everyone after.
Yeah, thanks, Abra. There's the website on the chat button. So really, really a lot of resources in that website. And then as far as the question of surveillance, so this is a question about monitoring the cancer for recurrence after treatment, specifically after curative treatment. So normally after radiation, there's a period of time of usually 12 weeks where there's a lot of inflammation in the throat, and a PET scan will be falsely positive in this area, and you can't actually see cancer through that. And so a PET scan is usually delayed until at least 12 weeks after radiation. The surveillance is actually the most important surveillance after treatment is direct visualization, so that ear, nose, throat doctor looks in the throat, through the nose down into the back of the throat, or just in, and can directly see if the cancer is returning, or if there's any concerns. That's actually the most sensitive way to pick up a recurrence. If there's any concern about lymph nodes or any symptoms suggesting like a cough or weight loss or things that suggest there might be something more serious, then a CAT scan is ordered, or a PET scan, but not within that first 12 weeks, as far as a PET scan. But really the follow-up is direct visualization. Like there's no schedule for, oh, you need a CAT scan every year or a CAT scan every 6 months. People get these scans if there's any symptoms of concern, but it's not a standard of care to have a scan after treatment. Like with lung cancer, there's a schedule every 6 months for 3 years, then once a year for the 4th and 5th year. In head and neck cancer, that hasn't been the case. It's mostly the ear, nose, throat doctor looking in the throat every 4 to 6 weeks for the first year or two. It's very frequent checks, and then they spread it out up to 5 years. So following it for 5 years. With a scan, if there's any concerns or lymph nodes of concern or anything else like that. There is one other thing though, if someone's been a smoker, then a CAT scan does make sense, especially if there's a cough or something, to check the chest for lung cancer, for second cancer, as well as a recurrence. It's not satisfying. People want to schedule, but that's kind of the standard. It's just been felt to be more effective to look and see. You can see the cancer before a CAT scan would pick it up. So yeah, hopefully that was helpful to the person. Anything else? Any other questions?
Thank you, Dr. Veatch. Good evening. Yes, this is Catherine. I'm a community member of the Cancer Support Community, and we're actually going to turn off the recording right now so that we can facilitate any questions and answers that were emailed into us for this workshop. If anybody has any additional questions, please feel free to unmute yourself or type it into our general chat. The first question that we